Hi there, my name is Jen. I am a rising fourth year applying into general surgery. I am so glad you're taking the time to watch these videos before your rotation and prepare as much as possible. I remember being super nervous to start my rotation. I didn't even know I wanted to go into surgery. I had just heard horror stories and stereotypes, and I thought it was going to be a very hard time. But it wasn't. It was absolutely amazing, and now here I am going into general surgery. So I think you're gonna have a wonderful time, and I really hope that you enjoy it. And at the very least, if all else fails, it's only 3 weeks, and I think you'll get to learn a lot. So this video is about presentations. At this point, you've heard a lot about presentations. We had CSLs on it. You've had orientation on it, so it's nothing new, but I wanted to tailor my video a little bit more for surgery presentations. What I have found are things that most, if not all, surgeons care about. There will be more detailed information that some attendings and residents will want you to present depending on what service you're in. So this is just a general outline, and I will have a linked outline for you to download if you so choose, if you find it helpful. If you're just wanting to skip this video and only see the outline, absolutely fine. Surgery has very early rounds, so you will more likely than not be the person to wake up your patient, and you'll have anywhere between 2 to 4 patients depending on your intern, depending on the service, depending on how complicated they are. So if you come in with an hour to pre-round or 30 minutes to pre-round, it can be hard to keep track of all the things you need to ask and to do it very quickly, that you don't spend too much time with any one patient and then run out of time before actual rounds. So I used it for the first week or two. This is a template that I created. Feel free to edit it. Feel free to not use it. It's something I found helpful that I'll have Dr. Cook put up on Sakai, and you guys can download it or at least take a look at it. First and foremost, depending on how many rotations you've been on, you know that third year is all about sounding totally stupid, saying something that's maybe textbook medicine but not real medicine, and being wrong 90% of the time, but saying it with confidence. Surgeons are no different. They really care about the assessment and plan. This is not internal medicine. You should get to know your patient as much as you can in the time that you have. You will be in the OR as much as possible, hopefully. So you might not have as much time to get to know your patient. Any downtime that you have, absolutely talk to them, spend time with them in the afternoon if you're not in the OR, but don't expect to present a very thorough history during the morning, because there are 8 a.m. cases to get to. So it's important to know what to present. And it's also important to, like I said, be confident and say it with confidence. So very often, and I include myself in these students too, we start third year by saying, well, I think maybe not even making eye contact and saying, I think that maybe, I'm not totally sure, but it might be possible that maybe the patient is progressing as I would hope, and I think that maybe we can think about advancing their diet if you guys think that's a good idea, but I'm not sure. So there was a lot of stuttering, no eye contact, maybe, ooh, I don't know. Residents are not going to let you kill a patient. They're there to teach you. So say what you want and say it as if you were a resident, and say, I think patient X is progressing appropriately as evidenced by X, Y, and Z, and I think that we should advance their diet as tolerated, period. And see what they say, and so they might say, okay, yeah, let's do that. Or they might say, well, actually, have you thought about this? Have you thought about that? Or what about the surgery they had? Wouldn't be a good option for them to proceed as quickly? This will be a great time to teach. Don't be afraid to just say it like you mean it, and you'll be corrected if you're wrong. Nobody will remember. The day will keep going. So it's okay to be wrong, but say it with confidence, with as few filler words as possible, with as little stuttering as possible. It will pay off, and it's a good habit to get into, because sub-Is, you also don't want to be stuttering and making poor eye contact. Something that was a little bit surprising to me and was different than the other rotations I had been on was that there are AM and PM rounds. I was at the VA, and during the week we did not present to any attendings for the morning rounds, at least. It was mostly the chief resident that we had presented to, any junior residents that were present, any interns that were present, any other PA student or medical student that was on the team. So it was a large team, but there was no attending, at least in the morning rounds. And throughout the day, the chief resident, the junior resident, and you will go to the OR and participate in operations. The interns rarely to never operate. They're mostly doing floor work, and so for afternoon rounds, usually the intern will be the one doing the presentations, even on your patients, since you've been in the OR all day and you don't quite know the updates, so it would be not as helpful of a presentation. If you have no idea what the updates are and are trying to catch up quickly between OR and presentation. So usually evening rounds, if your resident would like you to stay, are done by the intern. I recommend staying just because a lot can go on during the day. There are a lot of updates from the team. Sometimes the notes aren't as thorough for you to look at home. So if you're able to stay and kind of get the updates from the intern, that's helpful because you'll likely repeat those updates in the morning rounds just so that everybody's on the same page. Usually around Friday or sometimes the evening rounds, and definitely the weekend is when we would present to attending. So the weekend team was a lot smaller, but the attendings were there. So be prepared for that. Your presentations might want to be a little bit longer, more detailed, but usually they'll ask you what they want to know if there's anything else that they feel you should cover. Lastly, before going through the sections that I think are important for presentations, some patients will come out of the OR straight into the ICU and therefore will require ICU style presentations. So if this is not something you're comfortable with, either have the intern give you a different patient, or what I would recommend is just letting them know, hey, I've never done an ICU presentation, can you help me with that? And they will gladly help you so that you can be confident the morning of and give that presentation, because it's just good practice to be able to give an ICU presentation. All right, so first off is the ID statement. Everybody kind of knows this one, and it's not any different for surgery. So you're going to want to start with the age of the patient, usually male or female, man or woman if you've asked, post-op day X from X procedure. So for example, 74-year-old woman, post-op day 3 from a Nissen fundoplication procedure. That's it. Next is overnight events. You'll want to start with anything major that happened overnight. More likely than not, if it was something major, the resident will know what happened because they would have gotten a page. Did they fall? Did they have a code? Did they have super uncontrollable pain and the nurse had to page the intern overnight a bunch of times? This is also an appropriate place to mention anything that you got from the nurse, whether that's a nurse note, or if you were in the room when the nurse was in, if you were able to make the time to talk to the nurse beforehand. Nurses are our eyes when we can't be there, so it's wonderful to be able to get their input if possible, but sometimes it's a busy morning, they're running around, you're running around, and it's just not possible. If you're able to read through nursing notes, that's also helpful. The residents have 10, 15 patients to go through, so they're definitely not reading all of nurses' notes, so this is how you can really bring information that is new and valuable that they will not know. So, good practice to get into. Otherwise, there are 5 main parts to this objective that you'll be safe always asking and at least presenting, and if somebody wants you to not present on it, that's fine, they'll let you know. So first is pain. This is low-hanging fruit. Patients are in pain after an operation. This is your chance to suggest a change if something is not well controlled, if they're not taking the pain medication. Does something need to be added? Does something need to be changed? Does something need to be taken away? Can we change from IV to PO? Bonus points, and this is a pro tip, if you look at their medications tab and see what they're actually taking versus what they're prescribed, that is very helpful. It's a tedious task for residents to look that up for every single patient. If you're able to see what they actually take before even adding or changing anything, you can let the patient know, hey, did you know that you have X, Y, and Z on board? They might not know. Their nurse might not have told them. They might have forgotten. They might have gotten sleepy, and they're not asking and maximizing their current regimen. So first step is always maximize your current regimen. If that's not working, then possibly look into adding different modalities. If that's not working, getting a pain management team. There are many options. We don't just escalate immediately. So if you're able to know what they're actually taking, that's very helpful. Number 2 is nausea and or diet tolerance. So it's very common post-op to have nausea. Usually the order sets will have some sort of antiemetic. You can ask if it's well controlled, and if not, figure out if they're taking the medication that has been prescribed, if there's something that they know works better for them. Can also ask about that. This is one of the markers that we use to see if they can advance their diet. So it's a good one to know. Number 3, stool and gas. So this one can be a little bit awkward, especially for patients who have never been operated on. They wonder why you keep asking them if they've passed gas or if they've passed stool, but it can be a sign for us that they're progressing as we expect and that we can advance their diet depending on other factors, but this is a marker for that too. Also want to ask about diarrhea because they're in the hospital, C. diff. Get used to asking patients early in the morning, hey, have you passed stool yet, or have you passed gas? And it becomes second nature very quickly. Number 4 is ambulation. So we want patients to get up and walk, even if it's to the restroom, as soon as possible, within reason, of course. Studies have shown that the sooner they're able to get up and walk, it helps get back to normal. We know it helps for like DVTs, it helps digestion purposes, so we want them to do that as much as possible. Patients will be a little bit adamant, they're tired, they just had an operation, they don't feel great walking, they're in pain, but asking them if they've gone up and walked around, encouraging them to do so, coming up with a plan with their nurse to do so is also a great thing to ask about, and mention briefly in your subjective if they have ambulated or not. Number 5, anything that the patient tells you that is relevant. So most people will be pretty quiet at 5 in the morning, but you'd be surprised, some patients are chatty bright and early, and so it'll be a challenge to pick out what's important versus not. I try to bring up anything that the patient asks me. I usually ask my patient, what questions do you want me to bring up to the team as I'm about to leave the room, just so that I know and I can prepare my residents and my team in general for when they're going to come in and talk to the patient. If a patient is particularly upset, if they're feeling like their pain is not controlled, if they feel like they're being ignored, not listened to, anxious, whatever, I definitely make it a point to mention it during the end of my subjectives, just so that my resident, as they're listening, can come into that room prepared. If they have a question that even the resident doesn't know the answer to, then the resident can take a brief second to look that up and be prepared. It makes the team in general look good if the patient asks the question once the whole team is in the room and there's clear answers. The patient feels better. Maybe that patient is feeling particularly anxious that day, and if the team of 7 people comes in, it would make them feel worse. So I can let my resident know, hey, they're feeling a little bit anxious, and the chief resident might be the only one that sees them the second time around. So anything that you think is relevant, anything that you think will help your team work better and look better, definitely mention it at the end. Next is the objective section. So this one only has 3 parts. Start with the ins and outs. I start by stating the net, just so that my resident, attending, whoever is listening knows if the patient is net positive or negative, are they volume up, volume down. And then I go into the input is X PO, XIV. Output is usually what they care about a little bit more than the input, and I'll usually say this in cc's per hour. A good goal to have is greater than 30 cc's per hour. Feel free to round, no need to say 41 cc's or 41.9 cc's. 40 cc's per hour is great. Along with the urine output in cc's per hour, you also want to make note of any drains that are present and report the output of said drains. Usually you can report it in the last 24 hours, so a good goal is less than 30 cc's per 24 hours, and if that's been going on for a couple days, depending again on the surgery and depending on what each resident tells you, what the service is, you can add that directly to your plan and say the X output has been less than 20 cc's for the last 2 days, I would like to remove them. And that will again directly affect your plan and give you something to talk about. Also, mentioning the output isn't enough. You should mention the appearance. Is it serosanguinous? Is it bilious? Is it bloody? Is it feculent? Good descriptors to use. Number 2 on the objective is vital signs. So this is very dependent on who's listening to your presentation. For the most part, I found that residents are okay with you saying within normal limits or unremarkable. Some, every once in a while, will want you to list them all out and interpret them in terms of trends. I found it's just best to ask whoever's listening to your presentation what they prefer. At the very least, blood pressures seem to be important, and I've been told by various residents that unless it's higher than 160 or less than 100 systolic, they don't necessarily want to hear if it's 145 over 95, so keep that in mind. And lastly, number 3 is the physical exam. So this one will vary a ton depending on the service you're on, and I'm almost hesitant to include this section. I was at the VA, so it was very much general surgery. I mostly reported an abdominal exam every morning. It will greatly depend, again, on the specialty that you are on service for, but if you find yourself having to report an abdominal exam, 4 main categories or descriptors that I always included was whether the abdomen was soft, firm, distended, or flat, plus whether there was tenderness or not, if there was, where, what quadrant, plus the incision status, if there was erythema or not, if there was induration or not, if there was drainage or not, if there was, what color, and then the dressing status as well. So is there minimal strike through or was it saturated? So those 4 things, pretty much what I need to report for the abdominal exam. All right, now for the assessment, this is probably the shortest part unless there's been a post-op complication or for some reason there's a differential. If you're seeing a patient in the ED that you've been consulted on, then yeah, this will be a little bit longer, but usually if it's just the morning 6 a.m. rounds, then it's a quick ID statement, and then if they're progressing as expected, or if they have a prolonged post-op course. So something like 74-year-old woman, post-op day 3, status post Nissen fundoplication, progressing as expected or with prolonged post-op course. And that's the end of the assessment. And lastly, plan. This one will vary by patient, but some low-hanging fruit that you can always try and talk about if you have no idea what else is going on is, like I said earlier, pain. For example, do they have a PCA and can they transition off of it into PO medications? Is their pain well controlled? How often are they using it? Stuff like that. Pain is a very large topic that I will not even try to cover now, but if their pain is excruciating and we're at the point of opiates, some options are oxycodone, which is a PO only formula, morphine, which is IV and PO, hydromorphone, which is IV and PO. So these are just quick suggestions so that you can take your statement from, I think they should go from IV to PO medication. You can also say, I think we should start oxycodone X dose. It takes it a step further for your presentation. If the patient should not be having opioids for whatever reason, but they're still having breakthrough pain, a good medication to consider is Toradol. That is an IV NSAID, so keep in mind their renal status, their GI status, if there are any contraindications for that, but a good one to keep in mind. For oral non-opiate medications like acetaminophen and ibuprofen, a good rule of thumb is acetaminophen 1,000 milligrams Q6 to 8 hours and ibuprofen 600 milligrams Q6 to 8 hours. So if they're using about that much medication and it's not helping and they're taking it as scheduled, then it might be a good idea to suggest either adding another medication or changing the regimen to better control their pain. Other medications that can be helpful that are not necessarily always first line but should be continued if they are home medication or if a patient is not having success with their current pain regimen are things like a lidocaine patch or gabapentin. In terms of nausea plan, there are many options that are available. You can definitely look those up, but usually we use ondansetron, so Zofran, in the hospital. In terms of diet, you want to consider if the patient has passed gas or has had a bowel movement. If they have, then we might be able to progress as tolerated depending on the procedure that they had. So again, patients that have had a Nissen fundoplication will progress a lot slower just because of the surgery they had. Most patients you can say advanced is tolerated, but some patients or some attendings prefer to go from NPO to a clear liquid diet to a soft foods diet to a regular diet, and that'll just be preference. You can't guess that, right? So say what you think is best and run with it. Another great thing to bring up is any post-op complications specific to your patient's operation. So this will show that you have done some outside reading. Nobody expects you to know all the post-op complications. So if you're able to say something as simple as patient X doesn't show any signs or symptoms of Y complication, such as this symptom, this symptom, this symptom, which makes me less concerned. However, I will keep an eye out for those symptoms. It can be simple like that. It doesn't have to be the usual, according to last night's article, or from my reading yesterday, or I heard that. It can be a simple way to integrate reading that you've done into your presentation. Last couple of easy points: DVT prophylaxis, making sure that your patient is on it or that there's a plan in place to start a patient on it. If you want to go above and beyond, even checking that all patients are on DVT prophylaxis, unless there's a contraindication, is a great thing to do if you have downtime. And home medications, making sure that home medications are restarted, especially if there's a long stay. Things like anxiety medications, depression medications, if they're able to be restarted, it's helpful to not throw our patients off balance and switch up their whole regimen. Lastly, don't forget to mention disposition. This is a great thing to mention with every presentation. Shows that you're looking ahead, noticing how your patient is progressing, and have an opinion on when they might be ready to go home. All right, and that is the end of my outline. I hope that was helpful. Feel free to find the document on Sakai and print it, make a bunch of copies for yourself. I tried to make it fit into a half page so that you can take it anywhere as you're talking to your patients. Best of luck on this rotation. You're gonna love it. You might even become a surgeon, and I hope you had a great rotation.